Hello, and thank you to the ARTP for asking me to talk about one of my favourite subjects, CPET and clinical cases. So I've got 25 minutes and I'll try and make sure I stick reasonably to time and get started. So you'll have just heard a fantastic lecture on the cardiovascular and ventilatory responses to exercise. And I thought what I would do is just focus in a little bit on perhaps an area that's a little bit more familiar to me and one of my pet subjects, which would be the cardiovascular response to exercise. I guess as a pulmonary hypertension doctor, I'm spending a lot of my time focusing on the cardiovascular side, so I thought I'd do that. If you want to hear about the ventilatory side and some clinical cases, then you'll need to invite me back next year. These are my declarations of interest, and quite unusually for me, I have none on this occasion. So this is the cardiovascular response to exercise. And one of the key components, of course, is the cardiac output. This is done using invasive hemodynamics, measuring cardiac output and mixed venous saturations. And we see a roughly linear rise in cardiac output against VO2 on the x-axis. This is driven by a composite increase in heart rate and stroke volume. Now you'll note that stroke volume tends to max out and then plateau roughly at about 50% of peak exercise, which is kind of what the breathing does as well. We increase the tidal volume in the same way we increase the stroke volume, and the frequency increases with time. Now, in addition to that, what we have is a drop in mixed venous oxygen, so the oxygen content in blood returning back to the lungs. So we would normally measure this in the pulmonary artery, for example. And what this represents effectively is an increasing oxygen extraction by the muscles down to a point whereby no further oxygen can be extracted. And at that point, that typically coincides with peak oxygen delivery, of course, it is the point where exercise stops, where you reach your VO2 max. And one of the key measures we get on non-invasive exercise testing is the oxygen pulse, which is VO2 divided by heart rate, and this is represented on the bottom right-hand corner. And what this is an increase and a gradual further increase towards the peak of exercise. And this effectively is a composite of the stroke volume and the mixed venous and oxygen extraction. We can look at this in a mathematical sense as well. So if we just look at what oxygen consumption is, it's a product of flow multiplied by the oxygen extraction, so oxygen content in the arterial system minus that which is returning to the lungs. We can break, of course, cardiac output down into stroke volume and heart rate. Then we can further subdivide oxygen content into hemoglobin, which of course defines how much oxygen can be retained by the blood, and then multiply this by the saturation difference between the arterial and venous systems, and then there's a factor in there of 13.4. So what do we get on our 9-panel plot? Well, of course, we can measure hemoglobin, and I would encourage everybody to do that for every single exercise test, or at least to know what it is in reasonable proximity to the test. We can measure VO2, we've got heart rate, and we don't always have arterial oxygen saturation, but we can have a pulse oximetry for free. So we've got all of these variables ready and available to us, but we still have two unknown variables, the stroke volume and the mixed venous saturation, which we can't measure directly, unfortunately. So we've got the oxygen pulse. So if we rearrange this equation and take out the factor, then we have oxygen pulse is proportional to stroke volume multiplied by arteriovenous difference. Now, unless you've got something weird going on with variable oxygen delivery, for example, peripheral vascular disease, unless something weird like that is going on, you're going to see a linear increase in AV difference, so in oxygen extraction with exercise. So it does provide us with a fairly predictable response. And if we want, we can calculate stroke volume knowing what the AV difference will be in a maximal test. But knowing we have a linear increase, then what we can, so that's this graph down here on the bottom left. What we know is that with a linear increase in AV difference and an increase in stroke volume followed by a plateau, we should see a steeper rise in oxygen pulse at the beginning and then an ongoing rise, because while the stroke volume is plateauing, the AV difference is increasing, and so if you multiply a flat slope by an increasing slope, you still get an increasing slope. So the profile of the oxygen pulse is really important, and that's where I really want to focus my first few cases. So here's an example of a patient who was referred to us by a respiratory physician investigating someone who was breathless, who'd had a normal echocardiogram, and was referred with a diagnosis of restrictive lung function and normal gas transfer. Now, I'm not going to go into lung function interpretation, but you can see for yourself what's going on here, and there is an elevated BMI, which perhaps suggests the underlying pattern of the gas diffusion. He stopped because his legs were getting tired, his breathing was heavy but not too bad, and he had some chest tightness spread across his chest. So let's look at the 9-panel plot. Now we can see that his peak VO2 is lower than predicted. He's got a bit of ventilatory inefficiency, but really what I want to draw your attention to here is the oxygen pulse, and I've blown it up here on the right. And what you can see is, yes, this rise in oxygen pulse at the beginning, there's a little bit of wobbling around, and then we really have a fairly flat ending to the cardiopulmonary exercise test. So, based on what we've already discussed, what does that suggest? Well, if it's flat, if we know that oxygen extraction is increasing, then if that is flat, it must suggest that stroke volume is decreasing. Here's his resting ECG, normal axis, sinus rhythm. You can see that it's not quite normal. There is a really rather sort of poor R-wave progression across the chest leads. In fact, his CT scan showed really quite heavy and diffuse coronary calcification. Now, I'm not going to try and convince you of this ECG, and in fact that's the beauty of the case. Here we are at peak exercise, 119 watts. Now, I'm not hugely convinced, but there may be some inferior ST depression. Sometimes I find it much easier to look at the immediate ECG following exercise because you lose some of the wobble. Again, not brilliantly convincing, I would say. Perhaps some ST depression inferiorly AVF 2 and 3. I'm not massively convinced, and it wouldn't be something that I'd really write home about. But I think when you combine the surrogate features of the flat oxygen pulse, again with the chest pain, the CT calcification, I think this test certainly merits going forward with further investigation for ischemic heart disease. So some nice suggestions, nothing you'd really hang your hat on heavily, but enough to say to the referring physician, hey, look, have you thought about myocardial ischemia? I'm not going mad. This is a spirogram, and I'm still talking about stroke volume. I don't need to go into this in detail. And again, this is just a sort of a hanger just to talk to. You all know that on exercise in a normal subject, you will see an increase in tidal volume, and this will be because of a widening of the tidal volume and a lower end expiratory lung volume, or FRC. So you effectively expand over the mid-range in terms of the tidal breathing. But in somebody with airflow obstruction, say for example COPD, you'll see a gradual process of dynamic hyperinflation. Now this can have quite significant hemodynamic impacts. So if I just sort of graphicalize it here, if you hyperinflate, this is just my simple way of looking at it, then gas trapping will effectively stretch all the alveolar capillary beds, and that will increase the right ventricular afterload and decrease the left ventricular filling. And you often see this on CT scans, for example, in patients with bad gas trapping. You see small hearts, underfilled left-sided hearts. So you tend to think of bronchodilators as helping people exercise because they are you're decreasing the you're improving FEV1 effectively and improving airflow, but there are important cardiovascular effects. And this was a nice example of a saxophonist who had a diagnosis, it turned out to be asthma. It's a funny way of diagnosing it, of course, but it was a nice case example. You can see that we tested him pre-bronchodilator, and you can see here's the relative hypoventilation. He doesn't really get past his respiratory compensation point. Following a bronchodilator, he does push himself a bit further due to the relief of dynamic hyperinflation. And you can see how his heart rate goes further with and this isn't just a salbutamol effect, and his peak oxygen consumption increases significantly. But if we look at the variable of interest, the oxygen pulse, you can see pre and post bronchodilator, you just see just how much we've improved his peak VO2, and that's largely driven through an increase in oxygen pulse, which will be predominantly through an increase in stroke volume. Now, there's still some flattening here, so there's still some dynamic hyperinflation, but by relieving it in part, we've improved his cardiac output. So that's a really nice case, an example of cardiopulmonary interaction. So looking at some oxygen kinetics in a little bit of detail here. Now, this is a square wave where we apply a square wave of work, probably somewhere in the order of 150 watts-ish. And you can see how VO2 increases roughly at this fairly predictable rate of 8 to 10 mils per minute per watt. So 200 watt increase is about a 2 litre per minute increase in VO2. Doesn't matter who you are, how fit you are, the bottom line is you have to consume that amount of oxygen to produce that many watts. So this is a dynamic process, and if we measure at the what we measure at the mouth is of course delayed in terms of what happens at the muscle, and we have this concept of oxygen deficit and oxygen debt. So if we look at our ramp on exercise, then we can consider this as a set of mini steps, each with this little step of building up an oxygen deficit. But of course, with normal kinetics, this just ends up as a straight line. And that's the VO2 work rate slope. That's why the slope is the same as that absolute value I showed you of 8 to 10 mils per minute per watt. I always wondered how a slope like this could reflect kinetics, but you can see what happens with slow kinetics, and that's how it works. So it's not that somebody is just more efficient and they're able to do the same number of watts for less VO2, it's simply that the kinetics are slowing down the response. And so you can see, for example, like in our patient before, cardiac ischemia kicks in at a certain point, and so you can get a change in VO2 work rate slope, or if you have a problem throughout oxygen throughout the work, throughout the test, then it'll be the slope will be lower. So we've got some profiles here. In somebody who's obese, then simply turning the legs at 0 watts consumes more oxygen. So you've got this oxygen cost of unloaded pedaling, and the slope is shifted upwards, but the slope is still the same. Then if you have, for example, in heart failure, you'll have a decreased slope, and that's because of the slower kinetics. In other forms of cardiovascular limitation, for example, angina, etc., or something that progresses during exercise. So again, heart failure can look like this, or pulmonary hypertension, you'll see a tailing off. This is a really nice example, and I often use this to present. Because this is a guy who lived near me, and I knew the tube station he was talking about when he said, I just can't get to the top of Perivale tube stairs. There's quite a lot of them ever since my pacemaker box has been changed. Now, okay, the sensible physician would have just said, well, let's look at your pacemaker and reset it. But of course, what we wanted to do was have a look at the impact that this was having on his oxygen delivery. What you can see here is he's paced, atrial pacing. He's got atrial pacing, and then he's got this very long delay before spontaneous ventricular contraction. And that massive delay between atrial contraction and ventricular contraction is clearly potentially going to cause a problem, but you don't know until you prove it. And so, look, this is his oxygen kinetics. It's a bit noisy, but you can see this is actually a very extreme example of how this tails off. When we corrected his box settings, so he now goes from atrial sensing to ventricular pacing. You shorten the AV delay. You can see how this corrects very rapidly. So his oxygen kinetics have gone back to normal, and in some cases there have been reports of people using the VO2 work rate slope to optimize adaptive pacemaker programming. So we've looked at these various patterns of VO2 against work rate and oxygen pulse, and I think this is just quite a nice little example. This middle example here, this is the patient with coronary artery disease. You can see the VO2 increasing, the oxygen pulse increasing, plateauing, and then sometimes just beware, recovery isn't a period to just be ignored. We always do 3 minutes of recovery, and I suspect most of you do, and there's quite a lot of information to be gained in that period. And sometimes what you can see with the offset of exercise in coronary disease is this rebound increase in stroke volume. Now, this is a nice example of a young man who was in our pulmonary hypertension service. He was in his early 20s, I think, and we thought we were doing a pretty decent job with his idiopathic pulmonary arterial hypertension. It's a complicated case, and I won't go into detail because it's not really relevant. We only had him on one oral therapy because we thought he might have veno-occlusive disease. But anyway, at catheterization, his mean pulmonary artery was 37, a little bit higher than we'd like, really. His right atrial pressure was 7, so reasonably well controlled, good resting cardiac output, and a pulmonary vascular resistance of only 3.8 Wood units, so really quite low pulmonary vascular resistance. So we felt we were doing quite a good job, but he's kept on presenting with exertional syncope. Now, let's look at his 9-panel plot. What do we see? We see this flat oxygen pulse. In fact, rather worryingly, we see a fall off in oxygen pulse, so suggesting that the stroke volume is significantly decreasing during exercise. His ventilator efficiency, a marker of severity of pulmonary hypertension, looks reasonably good. So he doesn't have heart failure syndrome, so that's a bit of a puzzle. And you can see how his VO2 increases and plateaus. This is a true VO2 max. Looking here at his blood pressure, this is why he blacks out on exercise. So his blood pressure rises, then starts to fall. I realise that severe pulmonary hypertension and syncope are both contraindications to exercise, but we do have rather a lot of monitoring and people down there for cases like this. Now, look, you can see that there's also a slowing in his VO2 kinetics. So we did an invasive test. We put a right heart catheter in and exercised him and measured his pulmonary artery pressures and so on. So he gets up to a reasonable work rate of 130 watts. You can see, because he's lying supine, that his blood pressure doesn't drop quite as much, but it is starting to drop at the end of exercise, so dropping to 136 systolic, which is not particularly scary, of course. His saturations do gradually drop down on exercise, as you might expect in somebody with pulmonary vascular disease. The right atrial pressure goes from 7 and rises to 14 because his right ventricle's in trouble, and his mean pulmonary artery pressure goes up from 37 right up to 92. This is rocketing sky high on exercise. His left-sided pressures remain normal, as you'd expect. He doesn't have a problem with his left ventricle. He put a lot of effort in. He extracts down to a pulmonary artery saturation of 19%. His peak VO2 is the same as it was on his incremental test. Now, unfortunately, my little video's in the way here. What you can't see, unless I can move it, I don't think I can. The cardiac output increases up to about 12 litres a minute, but actually his stroke volume increases at rest from 114 to 136, and then it drops right down. And you can see the beginnings of this, but what happens is his pulmonary vascular resistance increases on exercise. So this guy goes into almost pulmonary vasospasm on exercise, which is very unusual. Now, of course, in a normal person, you would expect the pulmonary vessels to recruit, you'd expect the pulmonary vascular resistance to drop. In pulmonary hypertension, you might expect it to be fixed. In him, well, it worsens on exercise, which is a real surprise. So what did we do? We escalated therapy, and you can see that we obviously haven't cured him, but we have significantly improved matters with his oxygen pulse now sort of plateauing, or possibly with the eye of faith still increasing, and no further episodes of syncope. Here demonstrating how his blood pressure response to exercise is more normal, and his kinetics have improved. I'm going to stick with pulmonary hypertension, not that this is a common issue, but of course that it's quite nice to illustrate oxygen delivery. This is a 50-year-old woman who had pulmonary arterial hypertension from slimming drugs, and a history of OSA and gastric stapling, and had a sort of borderline restrictive defect. She did have severe pulmonary hypertension, pressures of 59, and a very high pulmonary vascular resistance, 21 Wood units. So you can see 7 times higher than the last guy. This is a long time ago when we usually just use monotherapy. We treated her for 3 months. And really, we're aiming for somebody to improve functional class to 2 and increase their walk distance significantly. But this was potentially inadequate. So should we give her more pulmonary vasodilator therapy? Well, let's look at her exercise test before and after treatment. So before and after treatment, we see that her peak VO2, okay, it doesn't skyrocket, but it goes from 51% to 64%, and we improve her anaerobic threshold, or whatever you want to call it, from 41 up to 57% predicted VO2 max. So we are improving her oxygen delivery. In terms of heart rate response, she does seem to be less tachycardic on exercise. There's a lot of noise on this. This is real life data. This is what you have to deal with. But if we look at her VO2 kinetics, we do see that there is, until you actually plot the slopes, you don't realize, but there's been quite a significant improvement in oxygen delivery in terms of VO2 work rate. Now, you don't always see this, of course, but it's good to look at for when you see it. Her ventilatory efficiency has improved a little. It's not perfect. And then when you actually look, and you look after 3 months, and look at what her MVV is and what her breathing reserve is, you can see that by improving her oxygen delivery, we've effectively taken her closer to her maximum voluntary ventilation. So in fact, the thing that's limiting her now is her lung volumes rather than her heart. So it does suggest that further addition of pH therapies may not necessarily bring about much improvement. So using oxygen kinetics to really drill down into that response. I'd like to look a little bit now at normal versus abnormal filling. So just focus on the top row here. This is the stroke volume. It's a little bit like the spirogram. On exercise, we see the stroke volume increase in blue in normals, but in people with abnormal filling, so people with stiff left ventricles, sometimes called heart failure with preserved ejection fraction, we see this is limited. And this is limited because when you go from rest to exercise, this is the left atrial pressure or the wedge pressure, and this is the left ventricular pressure. This pressure increases because the ventricle is stiff, and so it's harder for blood to get into the left ventricle, so it backs up in the pulmonary veins, the pulmonary arteries, and causes pulmonary hypertension effectively on exercise. And here you can see an increase in left atrial pressure increases the pulmonary artery diastolic pressure, which increases the overall pulmonary pressures, right ventricular pressures, and right atrial pressures. And we can test this out in the cath lab by giving saline or exercise. And in normal patients, we see the left atrial pressure is assessed by the wedge pressure. It increases, and in people with stiff ventricles, it increases further. And on exercise, this is even more exaggerated. So sometimes this is why we use exercise to look for HFpEF. I'm going to skip the slide, and I want to take you to my last case. This is a 57-year-old GP She is a long-distance open water swimming enthusiast, but she's getting more breathless during swimming now with cough and wheeze. She's been investigated by a pulmonologist already, with normal lung function, normal histamine challenge, no real help with bronchodilators. So we're concerned about swimming-induced pulmonary edema here. On a standard CPET, you might look at this and go, it's fine, what are you worried about? Peak VO2 is higher than normal, she's an athlete, heart rate response is normal. There is this subtle, very subtle O2 pulse. I don't want to make you paranoid now about O2 pulse. In the context of the history, you look at this and think, I wonder if something's going on. Now, lurking behind this was the most shocking, invasive hemodynamic exercise test. So, here are the watts. She gets up to 150 watts, her heart rate at 160. Her blood pressure response is pretty aggressive. SATs stay stable. Now, what happens to her mean PA pressure? It's completely normal at rest. Okay, give her a little bit of fluid, and it starts to creep up. The wedge pressure goes above 15. There's beginning of a suggestion here of a stiff left ventricle. She puts her feet up on the pedals, so further increasing the central volume load, and then you get her to exercise, and wow, look what happens. Her mean pulmonary artery pressure flies up to 53. You wouldn't really expect at a cardiac output of 10 for it to go above 30. So this is really high, and the wedge pressure is phenomenal. So this woman has a significant left ventricular filling impairment, and this may be what predisposes her to swimming-induced pulmonary edema. It could also be involved in, for example, things like high-altitude pulmonary edema. Now, unlike the last guy, this is what happens to her pulmonary vascular resistance. It falls on exercise absolutely as it should. So the pulmonary hypertension on exercise is nothing to do with the pulmonary vasculature. Her cardiac index rises, and you can see her stroke volume rises, but then also falls. So this is a really nice example, and just takes you back to some of the subtleties of the non-invasive CPET. Now, look, I do have one more case which is really interesting. In the interest of time, I suspect what they'll do is they will cut this, but I'm going to record this anyway for posterity, and if there's another way of you getting the slides, then fine, you can look at this case. I've really teased you now with it. If not, thank you very much for listening. Otherwise, I'm going to continue. So, last case, underfilling. So, now often we see patients with breathing pattern disorder, and they really scare me because you never know if this is truly just idiopathic hyperventilation or there's something underlying this. Now, here's somebody who presented with all the features of breathing pattern disorder, sort of panicky breathing, difficulty getting a breath in, and so on. Put her on an exercise test. One thing you notice, not uncommon, apprehension of exercise is sometimes an issue. Resting tachycardia when upright. But this isn't necessarily followed by a hugely tachycardic response, operating in a fairly narrow range. The oxygen pulse gradually rises, so suggesting that there isn't a change in a sudden sort of fall off in stroke volume. It could be low all the way though. I'm only saying that because I know the answer. Ventilatory inefficiency, probably in much driven by hyperventilation, and you can see that with the end-tidal CO2 dropping down here. A VT frequency graph that's all over the shop, and here is the exercise test, invasive exercise test. Now, the thing I want to draw your attention to is this very low right atrial pressure and left atrial pressure on exercise. This patient is underfilled. She's not just not drunk for 24 hours. This is what happens in people with POTS, postural orthostatic tachycardia syndrome, or orthostatic intolerance, or autonomic dysfunction. Their hearts are underfilled. That's why they're beating so fast. So the stroke volume here, as I told you, doesn't drop, but it doesn't particularly rise very much. Of course, she is supine. The pulmonary vascular resistance falls. Sorry, this is in different Wood units. And she's got a decent cardiac index on exercise. Now, we gave her 1,000 mils of fluid and then did the test straight after. Now look, the right atrial pressure goes up. It's sort of higher than it was before, and the wedge pressure is higher than it was before. So now her heart is better filled, and you can see the stroke volume instead of being 74, is now 111 mils. And where's the VO2 gone? It's a little bit higher. Now, so what we've demonstrated here is how an underfilled heart can underperform, and therefore there are various measures such as fluid and salt loading, fludrocortisone or midodrine, for example, that can be used to improve exercise performance. And how does this relate to dysfunctional breathing? Well, there are various theories about that, and I don't have time to go into that, but there are a number of people who believe that there is a strong connection between conditions such as POTS and dysfunctional breathing. Oh, I forgot about this case. Anyway, this is a real quickie. This is somebody who was being screened for pulmonary hypertension 2 years in a row. So this was 2018, I think, and this is 2020. And what can you see? A drop in peak VO2, a drop in oxygen pulse. The ventilator efficiency, well, you know, maybe it's got a little bit worse, possibly. What's happened? I can tell you she hasn't got pulmonary hypertension. If we look here, we can see how everything's dropped, peak VO2's dropped and so on. The oxygen pulse has dropped from 12 down to 8. Aha, what's going on? The hemoglobin has dropped from 14 down to 10. This woman had an episode of hemorrhage, and so everything has dropped commensurate with a drop in hemoglobin. So always worth having a quick look at that. So thank you very much. Thanks for your attention, and enjoy the rest of the conference.